Question 72. Which of the following auscultatory findings would best support the diagnosis? Auscultatory findings and then a bunch of stuff about the heart. So this is a cardio question. 54-year-old man presents with fatigue, progressive swelling of his lower limbs, and shortness of breath with exertion that onset 3 months prior. He completed treatment for Hodgkin lymphoma 1 year ago. On physical exam, his jugular veins are visibly distended and become more prominent during inspiration. Heart sounds are distant, and an extra low-pitched sound is heard in early diastole near the apex. His abdomen is distended with a shifting fluid wave, and hepatomegaly is noted. There is bilateral pitting edema to the knees. This guy has a lot of fluid in places it's not supposed to be. So they give us a few things here. Early diastole near the apex murmur. So early diastole, if we're thinking apex, that should make you think possibly mitral valve right away. Apex could be mitral. However, there are plenty of other strange symptoms going on here that we need to pay attention to. So he has jugular veins that are visibly distended and become more prominent during inspiration. So here we have our funky looking right atrium and our vena cava, both the inferior and the superior. And draining into the superior vena cava is going to be your jugular veins. Now, when you inspire, you decrease the pressure inside your chest, which acts like a vacuum pulling blood back towards the right atrium. Now, if for some reason the right atrium or down below at the right ventricle can't accommodate all that extra blood, then what'll happen is it kind of gets rerouted back into the vena cava, or it just won't enter the right atrium at all. So that's what that means. During inspiration, your venous pulse is supposed to decrease because now you're pulling that blood back to the heart. But this is telling us that there's something preventing blood from returning to the right side of the heart. So now we got to think, well, how does that relate to an apex murmur during diastole? Maybe it does, maybe it doesn't. Let's keep going. We also have distant heart sounds. Distant heart sounds is codename kids next door for a heart that's possibly, I'm not going to say that. Distant heart sounds is code for a heart that is possibly surrounded in fluid. So if we took our heart here and then dropped it into a water balloon, and then you put your stethoscope on here to listen, would it sound louder with the stethoscope on the water balloon itself? Or if we were able to put the water balloon directly on the heart? It should sound much louder, more clear with the stethoscope directly on the heart. But here in pericardial effusion, we are putting some extra distance between us. It's like when you have fluid in the pleural space. You can't hear the lungs as well because there's stuff in the way. So if you caught the distant heart sounds, you definitely should be thinking maybe pericardial effusion. Tamponade is more of an acute syndrome. So this guy has been having this go on for the past 3 months. Maybe we're more like in a restrictive pericarditis then. Hopefully you caught the distant heart sounds part because that is pretty pathognomonic for cardiac tamponade, generally speaking. Cardiac tamponade, maybe in this case with our Hodgkin lymphoma treatment, we should be thinking either chemo like a doxorubicin, daunorubicin, or radiation therapy. Radiation is just fibrosis city. Anytime you see radiation therapy, think fibrosis. If it's affecting the lungs, it's going to be interstitial lung disease. If it's affecting the heart, it's going to be restrictive pericarditis. And so without having his actual blood pressure here, we essentially have all parts of Beck's triad with the distant heart sounds and the Kussmaul sign. Then he's got a bunch of fluid everywhere else, suggesting right heart failure. But in this case, we know it's probably just the entire pericardium itself that's the problem. Okay, so let's go through these. Holosystolic murmur at the apex. Right, so if you didn't catch all these hints that it's probably the pericardium that's the problem and not the mitral valve, then this one is going to be very tempting. However, I hope you still ruled it out because this is a diastolic murmur, not a systolic murmur. So that one's out. Same with the next one, mid-systolic click at the apex. It's the same thing. I gave you 2 free answer choices. They never do that in the test. So these could represent like an MVP or mitral regurg, but that would all happen during systole. How about a third heart sound? Third heart sound is interesting. S3 always means dilated cardiomyopathy. S4 hypertrophic cardiomyopathy. Just memorize those. It'll help you on a lot of questions. So dilated cardiomyopathy could make sense if we're thinking this guy's super fluid overloaded with his hepatomegaly and his shifting fluid wave and edema to the knees. Sure, it could make its way from the left side, could back back up and cause pulmonary hypertension. Pulmonary hypertension could cause right-sided heart failure, and thus all these fluid signs we're seeing. But it's not going to explain the distant heart sounds or the Q-small sign. Q-small sign only happens when the interventricular septum, so if we were to finish drawing off our heart here, let's say we add in the right ventricle, and then the left ventricle is right here. Q-small sign only happens when the right ventricle can't expand to accommodate the extra load. So what'll happen is instead of the right ventricle expanding, the only thing that's still pliable in this case would be our interventricular septum. So the whole septum will kind of shift into the left ventricle. And that's where you see pulsus paradoxus, that drop in systolic blood pressure by 10 millimeters of mercury or more during inspiration. Pulsus paradoxus and Q-small sign are essentially related in that way. So this one's out just because it's not going to explain most of these findings here. It can explain the fluid, but that's it. Pericardial knock is exactly what happens when we're talking about our football in a water balloon. Essentially what happens is as the heart starts to fill up, you have to imagine normally you've got this heart and pericardium that are going to move in tandem. As the heart fills, the pericardium is going to allow that. It's going to be a little more compliant and allow the heart to fill inside of it. So it fills and contracts and fills and contracts. But in a restrictive pericarditis, the only thing that's able to move here is the heart. And eventually, once it fills up too much, it's going to knock into that restrictive pericardium and literally make the pericardial knock. It's just a sound you hear from the heart expanding quickly and bumping into the pericardium. So pericardial knock is looking pretty good. Let's just finish off with the opening snap. Again, apex mitral opening snap refers to the mitral valve, and this is what you would hear during diastole for a diastolic murmur, specifically mitral valve stenosis. It snaps open midway through diastole as the pressure in the left atrium finally overcomes the stenosed valve. And again, all that pressure in the left atrium can eventually result in pulmonary hypertension and right-sided heart failure, but that would take a long time, probably not just 3 months. It still would not explain the distant heart sounds and our Q-small sign. And of course, our history of being treated for Hodgkin lymphoma is a big red flag. So the correct answer here is D, pericardial knock.